Welcome to Prism Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, including physicians, trainees, nurses, pharmacists, and respiratory therapists. Each episode is designed for busy clinicians who want to understand not only the headline result, but also the clinical question, study design, key findings, limitations, and bedside relevance. The goal is to make new evidence easier to digest and more useful for real-world practice. Whether you are on service preparing for rounds, teaching learners, or simply trying to stay current. I originally started making these episodes to support my own learning and review. I am sharing them publicly in case they are helpful to other clinicians and learners who are trying to keep up with the growing critical care and pulmonary literature. Everything you hear is for educational purposes only and should not be taken as medical advice. Clinical decisions should always be made in the context of the individual patient, local practice standards, and the judgment of the treating clinical team. This week we discussed the NEXIS study. Can early cycling and extra amino acids prevent ICU survivors from leaving the hospital profoundly weak? In NEXIS, the strategy was feasible and appeared safe, but it did not improve walking, strength, or 6-month recovery.
Welcome to this deep dive. Today we're opening up a massive stack of data to explore a fundamental challenge in critical care.
Right, and our specific sources for this analysis are the primary manuscript of the NEXIS trial.
And that stands for Nutrition and Exercise in Critical Illness.
Exactly. Published in the American Journal of Respiratory and Critical Care Medicine, along with its extensive 70-plus page online data supplement.
Yeah, that supplement is dense. So our mission for you today is to basically cut through the noise, bypass the superficial summaries, and rigorously deconstruct the methodology, the intervention fidelity, and the outcomes of this trial.
We really want to figure out if combining early in-bed cycling with intravenous amino acids actually alters the trajectory of muscle wasting in mechanically ventilated patients.
Right. And before we proceed further, just to maintain strict objectivity, I will note that we were a site for the NEXIS trial.
Yes.
However, our focus today remains entirely on an independent, data-driven analysis of the published results.
Absolutely.
So to ground this, I want you to picture a patient who has survived the initial, highly unstable phase of acute respiratory failure on a ventilator.
You're standing right there at the bedside.
Exactly. The hemodynamics are finally stabilizing, the vasopressor requirements are trending down, and you're starting to think about liberation from the ventilator.
It looks like a success story in the making, right?
It does. But beneath that stabilizing clinical picture, there is a silent, completely devastating process occurring.
Yeah, the catabolism.
Right. This patient is facing severe muscle wasting, profound catabolism, and the rapid onset of intensive care unit-acquired weakness.
And we know from the literature that lean body mass losses can be 1.0 to 1.6% per day in the intensive care unit.
Which is staggering. To put that in perspective for you, a healthy adult might take months of total inactivity to lose what this patient is losing in just a matter of days.
Right. It's essentially the metabolic equivalent of a wildfire.
It really is.
Yeah.
And this massive loss primarily affects the lower extremities, which are, of course, critical for future ambulation, independence, and simply returning to a functional life.
And that catabolic reality is exactly why the intensive care community has been so eagerly examining this trial.
Yeah.
The biological hypothesis behind the NEXIS trial is inherently appealing because it attempts to address the limitations of treating this weakness, sequentially or in isolation.
Meaning just doing nutrition today and maybe mobility tomorrow.
Exactly. The rationale for combining these specific therapies relies on the concept of physiological synergy.
Right, getting them to work together.
Yes. Providing an exercise stimulus, specifically via in-bed cycling, theoretically increases skeletal muscle blood flow, which in turn promotes amino acid uptake at the cellular level.
So you're priming the muscle.
You are.
Okay.
And simultaneously providing aggressive nutritional substrate via intravenous amino acid supplementation ensures that the necessary building blocks for muscle protein synthesis are actually readily available in the circulation.
So the central hypothesis asserts that providing both concurrently could combat muscle wasting more effectively than either therapy administered alone.
Precisely. Previous studies, primarily in frail or older adults, as well as in prolonged bed rest models, have demonstrated that this specific combination improves protein synthesis and physical strength significantly more than either nutrition or exercise provided in isolation.
I mean, I understand the theoretical appeal and it sounds perfect on paper.
Right.
But as a clinician managing these patients daily, I have to question the biological plausibility of achieving that synergy in the early, highly acute phase of critical illness.
Right, because we're not talking about healthy adults on bed rest here.
Exactly.
Yeah.
When you were looking at a patient with acute respiratory failure, you were dealing with massive systemic inflammation, profound endocrine alterations, and heavily elevated reactive oxygen species.
It's a completely different physiological environment.
It is. So how realistic is it to expect that we can overcome this massive anabolic resistance simply by providing more substrate and utilizing passive or active movement?
That is the core question.
I mean, are we assuming the skeletal muscle can actually utilize these intravenous amino acids when the entire systemic milieu is aggressively driving protein oxidation and cellular catabolism?
Well, your skepticism regarding anabolic resistance is highly pertinent. And frankly, it is central to interpreting not just this trial, but the entire landscape of intensive care nutrition.
Because it's heavily debated.
Highly debated. The literature on muscle protein synthesis during critical illness is highly heterogeneous and complex.
Right.
Some metabolic tracing data suggest that muscle protein synthesis is not universally reduced in the intensive care unit.
Wait, really?
Yeah. Rather, it is the balance between that synthesis and a massive unchecked degradation that is the core issue.
Ah, I see.
The degradation pathways, particularly the ubiquitin proteasome pathway, are massively upregulated by inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha.
So the breakdown is just completely outpacing whatever synthesis is happening.
Exactly. Furthermore, the exact physiological mechanisms regarding the rapid oxidation of amino acids remain a critical barrier.
Right, because of the oxidative stress.
Yes, during periods of severe systemic illness, you have elevated reactive oxygen species causing mitochondrial dysfunction within the muscle cells.
Which means the fuel isn't being used properly.
Precisely. It is highly plausible that critical illness leads to such high levels of oxidative stress that administered proteins are rapidly oxidized, or they're just diverted to the liver for gluconeogenesis and acute phase protein synthesis.
Right, before they ever even reach the skeletal muscle to build tissue.
Exactly. Ultimately, this fails to prevent cellular damage and catabolism.
So the NEXIS trial was explicitly designed to test if applying concurrent physical rehabilitation could overcome this exact anabolic resistance.
Yes, by mechanically and physiologically enhancing the drive for protein utilization right at the muscle receptor level.
So it is an attempt to force the body to use the building blocks by creating a mechanical demand.
That's a good way to frame it.
That sets a fascinating stage for the trial design. Let us unpack the framework they utilized to test this hypothesis in such a challenging environment.
Let's do it. This was designed as a multi-center phase 2 randomized controlled trial featuring blinded outcome assessment.
And it was conducted across 9 United States academic centers.
Yes. When you look at the inclusion criteria, they targeted adults requiring mechanical ventilation for acute respiratory failure.
With an expected total duration of mechanical ventilation of greater than 48 hours.
Right, and an expected intensive care unit stay of greater than 4 days.
So they were specifically looking for that window where the patient is sick enough to experience the wasting, but stable enough to potentially intervene.
Precisely. And the exclusion criteria are equally critical to understanding the specific study population and interpreting the eventual outcomes.
What were the major exclusions?
Well, they specifically excluded patients who had been in the hospital for more than 5 days prior to their intensive care unit admission.
Analytically, that makes a lot of sense. It was a deliberate and necessary methodological choice.
It was. It ensures the intervention was evaluated in the early phase of critical illness, before massive, irreversible muscle wasting had already occurred and cemented the patient's physical trajectory.
Right, you have to catch it early.
They also excluded patients with severe cognitive or neuromuscular impairments, those with pre-existing primary systemic neuromuscular disease, and critically, those who could not ambulate independently prior to their acute illness.
Which, I mean, those performance-based exclusions are entirely inherent to trials that rely on functional primary outcomes like walking distance.
Absolutely. But as we evaluate the data, you must keep in mind that they strictly narrow the generalizability of the findings.
Yeah, you cannot automatically extrapolate these results to your chronically bedbound nursing home patients who are admitted with pneumonia.
That is a crucial distinction for anyone trying to apply this literature on morning rounds.
Now, the enrollment realities of this trial reflect the profound logistical challenges of conducting intensive care unit rehabilitation research, particularly in recent years.
Right, the data clearly show that 115 patients were successfully randomized.
60 were allocated to the active intervention group and 55 to the usual care control group.
However, when you dig into the methods, the planned target was actually 142 patients.
We must note that enrollment was stopped early due to slow recruitment, a factor heavily impacted by the systemic disruptions of the COVID-19 pandemic.
And ultimately, the exhaustion of the trial's funding limits.
The premature cessation of enrollment fundamentally affects the statistical power of the trial, which is an issue we will need to analyze in deep statistical detail when we reach the outcomes.
We will. But first, we must examine the intended versus achieved targets to rigorously evaluate the intervention fidelity.
Because testing a hypothesis requires that the intervention was actually delivered as designed.
Exactly. The intended protocol was highly specific and ambitious. It mandated 45 minutes of daily in-bed cycling.
That's a significant amount of time.
It is. This utilized a specialized motorized cycle ergometer positioned at the end of the bed.
And the protocol dictated that therapy should progress from passive cycling, where the motor does the work for a sedated patient, to active cycling.
Right, utilizing gears 0 through 20 as the patient's wakefulness and strength improved.
Concurrently, the nutritional protocol targeted a total protein delivery of 2.0 to 2.5 grams per kilogram of ideal body weight per day.
That is an aggressive target. It was achieved by taking the patient's standard enteral nutrition and supplementing it with a 15% clinisol intravenous amino acid infusion.
Just to make up the difference between the enteral delivery and that high-dose target.
Yes.
I have to admit, when I first saw this protocol, targeting 45 minutes of cycling in an intubated patient with acute respiratory failure sounded incredibly ambitious.
It does sound like a lot.
The reality of the intensive care unit involves managing central lines, arterial lines, endotracheal tubes, frequent radiologic procedures, and fluctuating hemodynamics.
It's a chaotic environment.
But looking at the achieved clinical reality reported in the supplement, the intervention delivery was actually quite rigorous.
It really was. For those cycling sessions that were successfully completed, the duration averaged 40 plus or minus 7 minutes.
That is remarkably close to the 45-minute target.
It is. It's also important to note that there was 0 protocol cycling occurring in the usual care group,
which maintains a clear methodological separation in that specific exercise modality.
Furthermore, the trial successfully achieved a distinct metabolic separation.
The intervention group received a total protein delivery of 1.9 plus or minus 0.6 grams per kilogram per day.
By contrast, the control group received 0.9 plus or minus 0.6 grams per kilogram per day.
From a purely methodological standpoint, the achievement of that nutritional contrast is a significant strength.
It is. When you review the history of critical care nutrition literature, trials frequently fail to achieve meaningful separation between the treatment and control arms.
Right, due to the widespread use of supplemental parenteral nutrition or aggressive enteral feeding protocols in the control groups.
Exactly. So achieving a full gram per kilogram per day difference is substantial.
However, to rigorously evaluate the specific biological hypothesis of synergy, we must look beyond isolated delivery and examine the concurrent delivery.
Right. Did the exercise and the substrate arrive at the muscle at the exact same time?
That is precisely the clinical question. The protocol was undeniably complex.
It targeted 5 consecutive days of this combined therapy, followed by 5 out of 7 days thereafter for the duration of the intervention period.
In the chaotic environment of the intensive care unit, with procedures, sudden hemodynamic instability requiring escalating vasopressors, and inevitable staffing variables, what percentage of days did these patients actually receive both the cycling and the intravenous amino acids together?
Well, according to the granular data provided in the online supplement, 73% of the expected treatment days featured the concurrent delivery of both interventions.
Okay, 73%.
When we break that down, the intravenous amino acid infusion was delivered on 91% of the expected treatment days.
Which speaks to the ease of administering a continuous intravenous infusion.
Right. It just runs on the pump. However, the cycling intervention was only delivered on 75% of the expected days.
And why was that?
This discrepancy is largely attributable to predefined clinical safety criteria that prevented the initiation of a cycling session.
Like refractory hypoxia or sudden cardiovascular instability.
Yes. Other factors included patient refusal, which is common as patients awaken and experience delirium or pain, or, quite simply, physical therapy staffing unavailability.
Right. Therefore, while the intervention fidelity is highly commendable for a complex, multi-component intensive care unit trial, the core synergy hypothesis was only truly tested on approximately 3/4 of the available treatment days.
That is a vital context for evaluating the results.
Let us pivot to those outcomes, which evaluate the ultimate clinical efficacy of that delivered bundle.
We frequently view hospital discharge as a critical defining milestone for our intensive care unit survivors.
It absolutely marks the transition from acute life-saving care to chronic rehabilitation.
And the primary outcome the investigators selected to represent this milestone was the 6-minute walk distance.
For those who might not administer this test daily, the 6-minute walk distance is a validated measure where we simply measure the total distance a patient can walk on a hard, flat surface in exactly 6 minutes.
Right. It provides a global assessment of functional capacity, integrating cardiovascular, pulmonary, and neuromuscular function.
So what were the results?
The specific primary outcome data for this metric revealed that the distance walked at hospital discharge was statistically similar between the two groups.
Similar. Okay.
The intervention group achieved a median distance of 108 meters, whereas the control group achieved a median distance of 95 meters.
When you stop and look at those exact figures, 108 meters versus 95 meters, you recognize immediately how profoundly limited the mobility is for these patients at the point of acute care discharge.
Yes. We are talking about walking roughly the length of a football field or less in 6 full minutes.
The raw distance is definitely sobering, but we must rigorously analyze the explicit statistical output associated with those figures.
The statistical analysis yielded a median difference of exactly 10 meters between the groups.
And the confidence interval.
The 95% confidence interval for this difference ranged from -75 meters to +84 meters, with p equals 0.51.
Analytically, we must emphasize that this confidence interval is exceptionally wide and statistically imprecise.
It is incredibly wide. Let us unpack that for a moment, because understanding that confidence interval is critical for you at the bedside trying to interpret this data.
Right. When you see a 95% confidence interval spanning from -75 to +84, what does that actually imply for clinical decision-making?
It implies a high degree of statistical uncertainty, due to the variance in the data and the reduced sample size.
Because the interval spans from a potential substantial harm, meaning the intervention group could theoretically walk 75 meters less than the control group, all the way to a potential massive benefit of walking 84 meters more, the trial simply cannot definitively rule out clinically important benefits or clinically important harms.
Exactly. In the established pulmonary and critical care literature regarding the 6-minute walk distance, a clinically important difference, the threshold where a patient actually feels a difference in their functional capacity, is generally considered to be in the range of 20 to 30 meters.
And because our confidence interval easily swallows that 20 to 30 meter threshold in both the negative and positive directions, the result is statistically neutral.
But the imprecision severely limits our ability to declare the combined intervention definitively ineffective. We just lack the statistical power to make a conclusive definitive statement either way.
That wide confidence interval essentially forces us to look closely at the secondary inpatient outcomes.
Right. We need to see if a consistent clinical pattern emerges that might point toward benefit or harm, even if the primary outcome lacked precision.
The trial measured a highly comprehensive suite of physical metrics. They assessed the Medical Research Council SUM score.
This is a bedside physical exam where we test muscle strength across 6 muscle groups on both sides of the body, grading them from 0 to 5 for a total possible score of 60.
And a score below 48 is generally the diagnostic threshold for intensive care unit-acquired weakness.
They also measured quadriceps force directly via handheld dynamometry.
Furthermore, they assessed physical function using both the short physical performance battery, which evaluates balance, gait speed, and chair stands, and the functional status score for the intensive care unit, which looks specifically at critical mobility milestones like rolling, supine to sit, and standing.
Beyond those physical metrics, they evaluated standard clinical metrics, including the total duration of mechanical ventilation, intensive care unit, and hospital length of stay, and the patient's ultimate discharge location.
So a very robust secondary analysis.
Very robust. But when we evaluate that comprehensive data set, the findings are remarkably consistent.
In what way?
In every single one of those secondary inpatient outcomes, there were no clinically important or statistically significant differences between the intervention and control groups.
None at all.
None. For example, the Medical Research Council's sum score medians at hospital discharge were 56 in the intervention group versus 57 in the control group.
So essentially identical.
The functional status score for the intensive care unit at hospital discharge was 30 versus 29 out of a maximum of 35.
And what about the clinical metrics?
The median duration of mechanical ventilation was exactly 95 hours in both groups. Intensive care unit length of stay was 8.6 days versus 8.2 days.
The trajectory of physical, respiratory, and clinical recovery was nearly perfectly identical across all measured parameters.
Yes. And when we extend the timeline out to the 6-month patient-reported outcomes, we see that exact same alignment persisting.
They utilized the SF36 version 2 and the EQ5D5L.
These are deeply validated, standardized surveys designed to assess health-related quality of life, looking at everything from physical functioning and pain to social functioning and emotional well-being.
They ran these alongside specific validated scales for anxiety, depression, and post-traumatic stress disorder, which we know are massively prevalent in this survivor population.
The 6-month longitudinal data absolutely confirm the inpatient findings.
The median physical component summary score of the SF36 was 40 in the intervention group versus 43 in the control group.
To provide context for those numbers, a score of 50 represents the normative mean for the general population.
Therefore, both groups are scoring approximately 1 full standard deviation below the age and sex-matched population norm at 6 months post-discharge.
Furthermore, there were no statistically significant differences in downstream healthcare utilization, the rate of return to work, or the ability to live independently.
The complete lack of separation between the two trial arms persists across the entire measured continuum of critical illness recovery.
This brings the focus back to a truly sobering bedside reality for both cohorts.
Regardless of the group assignment, regardless of whether they received aggressive intravenous amino acids and protocolized cycling or standard usual care, both sets of patients remain severely physically impaired at the time of hospital discharge.
The data contextualizing the depth of this impairment are striking, and they deserve careful attention.
When comparing the achieved 6-minute walk distance to population normative values based on the patient's age, height, and sex, the patients averaged only 30% of their predicted normal walking distance at the time of discharge.
Similarly, objective measurements of right-hand grip strength equated to roughly 17 to 21% of their predicted normal values.
This underscores the devastating, systemic, and long-lasting impact of intensive care unit-acquired weakness.
It demonstrates objectively that our current standard of care, even when delivered in highly resourced, top-tier academic medical centers, currently leaves patients profoundly disabled at the point of acute care hospital discharge.
Given that profound baseline of disability, evaluating the safety of any new aggressive intervention is absolutely paramount.
We cannot risk making a terrible situation worse.
We must conduct a rigorous, objective safety appraisal of the NEXIS protocol, looking closely at both bedside events and metabolic alterations.
Safety analysis in critical care trials must be framed neutrally and highly analytically. We must explicitly avoid binary or generalized claims, categorizing an intervention as either perfectly safe or definitively harmful.
Right, the intensive care unit environment is inherently volatile, and the baseline acuity of patients suffering from acute respiratory failure mandates a nuanced interpretation of all reported adverse events.
We expect adverse events in this population. The analytical task is determining causality.
To that end, it is notable and reassuring that no serious adverse events occurred during the actual active cycling sessions themselves, whether they were the protocol cycling sessions in the intervention arm or the usual care physical therapy sessions in the control arm.
We didn't see accidental extubations or central line removals during the exercise.
Furthermore, the hard, definitive endpoint of mortality was statistically similar across both groups.
Hospital mortality was 12% in the intervention group versus 13% in the control group, with p equals 0.86.
And at the 6-month mark, mortality was 19% versus 21%, with p equals 0.81.
However, we cannot stop at mortality. We must highlight the specific safety signals documented in the supplementary appendix.
Right. Serious adverse events were numerically higher in the intervention group, occurring 8 times compared to 3 times in the control group.
These events included severe pathologies such as embolic strokes, unanticipated reintubations, and aspiration pneumonia.
But we must apply a strict analytical caveat here regarding trial methodology, which is that the reporting of these serious adverse events was unblinded.
Yes, the local clinicians knew which treatment arm the patient was in.
Furthermore, the local site investigators formally categorized all of these events as either not related or unlikely related to the study interventions.
So, while the numerical imbalance clearly exists in the data, the methodology of unblinded reporting in a highly complex, critically ill patient population severely limits our ability to draw a direct, reliable causal link between the intervention bundle and these specific serious adverse events.
That makes sense. But let us dig deeper and examine the metabolic safety signals, particularly regarding the aggressive protein delivery.
We are pumping these patients full of intravenous amino acids.
When you review the lab values detailed in the online data supplement, specifically focusing on markers of protein breakdown and renal handling, what metabolic signals actually emerge?
The metabolic data reveal a highly distinct and measurable physiological response to the intravenous amino acids.
Yeah, what do they find?
The blood urea nitrogen, along with the blood urea nitrogen to creatinine ratio, increased significantly in the intervention group.
By day 7 of the protocol, the median blood urea nitrogen was 50 milligrams per deciliter in the intervention group, compared to 33 in the control group.
Which represents a statistically significant difference. Importantly, throughout this period, the serum creatinine levels remained stable and statistically similar between both groups.
For you listening and managing these labs daily, an isolated rise in blood urea nitrogen without a concomitant rise in creatinine, specifically in the setting of aggressive amino acid infusion, is a major physiological tell.
It is. It strongly suggests that the exogenous protein delivery is fundamentally exceeding the body's actual capacity for muscle protein synthesis.
It's like delivering a massive continuous shipment of expensive bricks to a construction site where the structural workers are entirely on strike.
That's a perfect analogy.
The bricks aren't being used to build the building, they're just piling up, getting in the way, and the site manager has to pay to have them hauled off.
In the body, the excess amino acids are being rapidly deaminated in the liver, leading to increased urea production, which then shows up as an elevated blood urea nitrogen.
It points directly back to our earlier discussion of severe anabolic resistance. The body is simply oxidizing the delivered substrate rather than utilizing it to build skeletal muscle.
We also see some direct bedside complications associated with the physical delivery mechanism of this concentrated nutrition.
Right. Phlebitis, or intravenous extravasation, occurred 4 times in the intervention group versus only 1 time in the control group.
Additionally, azotemia, which the trial defines specifically as a blood urea nitrogen level greater than 100 milligrams per deciliter, occurred 2 times in the intervention group versus 0 times in the control.
These specific metabolic and bedside signals powerfully reinforce the need for objective appraisal of aggressive nutritional interventions.
While the intervention bundle did not cause an increase in overall mortality, the administration of high-dose intravenous amino acids definitively alters metabolic parameters, specifically driving significant urea generation.
Furthermore, the requirement for continuous infusion carries inherent mechanical and infectious risks related to venous access.
Contextualizing this neutral trial result is absolutely vital for your clinical practice.
A neutral result in this specific context does not equate to clinical proof that nutrition or rehabilitation are unimportant in the intensive care unit.
That would be a dangerous misinterpretation.
Instead, a neutral result requires us to meticulously deconstruct the methodological limits of the trial to understand exactly why this specific, biologically plausible bundle did not yield the hypothesized clinical benefit.
The primary methodological limitation, as we touched upon briefly earlier, is that the trial was substantially underpowered.
The investigators conducted rigorous pre-trial power calculations and planned for an enrollment of 142 patients to detect a meaningful difference.
However, they were forced to stop at 115.
This truncation directly and mathematically contributes to the exceptionally wide confidence interval surrounding the primary outcome of the 6-minute walk distance.
A larger sample size, assuming the same variance, would have mathematically narrowed that interval, potentially revealing a statistically significant, albeit perhaps modest, clinical effect in either the direction of benefit or harm.
The initial statistical power calculations assumed a certain data distribution and standard deviation that became increasingly difficult to satisfy with the heavily reduced sample size.
We also have to scrutinize the highly heterogeneous delivery of the intervention itself.
While the cycling duration averaged a very respectable 40 minutes per completed session, diving into the data supplement reveals a crucial detail.
39% of those cycling sessions were entirely passive.
This occurs frequently and unavoidably in the intensive care unit due to requirements for deep sedation, neuromuscular blockade, or simply the profound severity of the critical illness preventing patient participation.
However, if nearly 40% of the exercise stimulus is entirely passive, it fundamentally alters the theoretical active exercise biological hypothesis that underpins the entire trial.
Passive movement is excellent for preserving joint range of motion and preventing contractures, but physiologically, it likely does not generate the same degree of skeletal muscle blood flow.
Nor the same metabolic cellular demand for amino acid uptake as active resisted cycling does.
Furthermore, we must critically analyze what we call the usual care contrast limitation.
Right. In randomized controlled trials evaluating physical rehabilitation, particularly in modern academic centers, the control group rarely receives zero therapy.
It would be unethical to withhold standard physical therapy.
In the NEXIS trial, the control group received highly meaningful usual care rehabilitation, averaging 13 plus or minus 16 minutes per intensive care unit day.
This is compared to the 42 plus or minus 25 minutes of total rehabilitation per day in the intervention group.
While there is undeniably a clear, statistically significant separation in total minutes, delivering 13 minutes of targeted physical and occupational therapy per day to a critically ill control group establishes a relatively high baseline standard of care.
This high baseline inherently narrows the measurable contrast between the two study arms.
When the control group is already receiving a beneficial standard of care, it makes it exponentially more difficult for the experimental intervention to demonstrate a statistically significant superiority, even if it provides a marginal biological benefit.
You also have to carefully consider restricted generalizability when evaluating these trials for application in your own hospital.
Exactly. The demographic and enrollment data show that 73% of the trial participants were recruited from just 3 of the 9 participating academic centers.
This heavy geographic and institutional concentration means the final results are heavily influenced by the specific intensive care unit cultures, nuanced sedation practices, mechanical ventilation weaning protocols, and baseline mobility standards of those 3 specific hospitals.
If their usual care is exceptionally good, it skews the entire trial.
Furthermore, the stringent exclusion criteria we discussed earlier restrict generalizability. As noted, 36% of all screened patients were excluded simply for being in the hospital greater than 5 days prior to their intensive care unit admission.
And we absolutely must highlight the 2022 protocol amendment regarding acute kidney injury, because this drastically alters who we can apply this data to.
Yes. Midway through the execution of the NEXIS trial, the Independent Data and Safety Monitoring Board approved a major protocol amendment to completely exclude any patients presenting with acute kidney injury.
This sudden shift was prompted by severe safety signals emerging concurrently from a separate, massive pragmatic trial called the EFFORT protein trial.
Right. The EFFORT protein trial, which evaluated high-dose protein provision alone in critically ill patients, suggested potential harm, specifically a signal for higher mortality in the specific subgroup of patients suffering from acute kidney injury.
Consequently, to protect patient safety, the NEXIS trial immediately excluded these patients.
What this means analytically is that we have absolutely zero data from this trial on how this combined intervention affects the acute kidney injury subpopulation, which is an incredibly vulnerable and exceptionally common demographic in any intensive care unit.
Which brings up a critical structural question regarding the trial design itself.
Given that this was designed and executed as a bundled combined intervention, meaning intravenous amino acids combined simultaneously with in-bed cycling, is it statistically or methodologically possible for us to separate the independent clinical effects, or the lack thereof, of the cycling from the intravenous amino acids?
Methodologically and statistically, it is entirely impossible.
The trial was explicitly designed to test the synergy of the complete bundle against a usual care control group.
Because there are no distinct separate study arms evaluating the in-bed cycling alone, or evaluating the intravenous amino acids alone, we cannot separate their independent physiological or clinical effects.
From the data provided, we cannot conclusively determine if the aggressive amino acids somehow negated a positive functional effect of the cycling.
Or, conversely, if the cycling intervention mitigated a negative metabolic effect of the high-dose amino acids.
We can only evaluate the net clinical effect of the combined package, which, as the data demonstrates, was neutral.
So synthesizing all of this granular methodology, metabolic data, and statistical nuance, what is the ultimate clinical takeaway for a practitioner rounding in the intensive care unit tomorrow morning?
When you are standing at the bedside of a patient with acute respiratory failure, how does this alter your management?
The rigorous, evidence-based bottom line is this. The NEXIS trial does not support routinely adding intravenous amino acids and extra in-bed cycling to standard care solely to improve physical recovery in patients with acute respiratory failure.
Clinicians should absolutely maintain standard evidence-based enteral nutrition and early mobility practices as dictated by current international guidelines.
Furthermore, the metabolic data from this trial strongly reinforces the emerging critical care concept that more protein is not always better.
This is especially true early in the highly acute course of critical illness when systemic anabolic resistance is at its peak.
Or in the presence of acute kidney injury, where aggressive amino acid loading may pose a distinct, measurable risk of metabolic harm.
That leaves us with a truly provocative final question for you to mull over as you analyze the current trajectory of critical care nutrition.
If early, aggressive nutritional substrate delivery is simply oxidized or entirely blocked by massive early anabolic resistance in the intensive care unit, perhaps our entire research focus needs to shift.
Instead of continuously asking how much protein and how much exercise we can physically deliver to these patients, should our focus shift to identifying the exact metabolic biomarkers that can reliably tell us when a specific patient's body has finally exited the massive catabolic phase and is actually physiologically ready to utilize these interventions for true tissue anabolism?
That is precisely where the next generation of critical care research must focus its efforts to make meaningful progress.
The NEXIS trial shows that a biologically plausible and well-delivered package of early cycling plus intravenous amino acids was feasible and appeared safe, but it did not translate into better walking, strength, or 6-month recovery than the usual care prof.
Thanks for spending your time with Prism Rounds. If this episode was useful, please like, follow, or subscribe, and share it with a colleague. Leave a comment with your bedside takeaway, a question, or a paper you'd like covered next. Your feedback helps shape future episodes. Thanks again for listening. Educational use only, not medical advice.
Woke up to the hum of the ICU, lying in a bed, feeling black and blue. A machine on my throat just to help me breathe, wondering if I'll ever find the strength to leave. And then the doctors walked in with a brand new plan. Said they're gonna make me a walking man, hook me up to a cycle right there in my bed, plugging amino acids straight into my head. Oh, they called it the NEXIS, a phase 2 ride, trying to build some muscle on the inside. 40 minutes of pedaling day after day, hoping it would chase the weakness away, just trying to make it to that 6-minute walk. But the numbers don't lie when the doctors talk. They randomize the draw, 1-to-1 they go. 60 in the saddle, 55 in the control. We fed on the protein, we spun those gears, trying to fight off the wasting and the quiet fears. But the wind got heavy and the road got long. COVID came around and the funding was gone. They stopped the recruitment before the finish line, leaving us to wonder about the grand design. Oh, they called it NEXIS, a phase 2 ride, trying to build some muscle on the inside. 40 minutes of pedaling day after day, hoping it would chase the weakness away. Just trying to make it to that 6-minute walk, but the numbers don't lie when the doctors talk. When we got to discharge, they measured the pace, but both of our groups ended up in the same place. 108 meters versus 95, no real difference, though we're glad we're alive. 6 months down the road, the surveys all say we're carrying the same heavy load today. Yeah, the trial was safe, no harm was done, but it didn't bring back the strength we wanted one. Still in this bed, watching the monitors glow, just a country boy wishing my legs would go. Yeah, just wishing my legs would go.